So our next speaker is Dr. Jessie Gaeta, who, Jessie, are you here? You must be. Oh, there you are. Jessie is an assistant professor of medicine at BUSM. She's the chief medical officer of the Boston Health Care for the Homeless program. And she's going to tell you, if you're leaving the room, I suggest you don't, because you're about to hear something really cool. You're about to miss out on something. She's going to talk to us about harm reduction and research, the evaluation of SPOT.
Hello, I'm not sure you're missing out on that much, but thank you for being here still. And thank you for the Gaeta Center for the invitation to present today. I thought I would pause for a minute to say how proud I am of this institution, and I was thinking about it this morning more so at this moment in time than in any other point since I walked in 20 years ago this month to start my training in internal medicine. I think about the breadth of research activities in substance use disorder, the unwavering mission of the institution, the incredible care that people who use drugs and who suffer from addiction receive here. I know I speak for everyone at Boston Healthcare for the Homeless program in saying that we're so fortunate to be a small partner with BMC and the Gaeta Center in this work in the midst of really an unprecedented and sometimes bleak epidemic on Albany Street and beyond. So thank you to everyone who's here for your hope, your deep commitment, your fearlessness, really, and vision. So Dr. Volkow explained this morning NIDA's framework for supporting research to end the opioid crisis as a triangle with pain management at the top and opiate use disorder at one corner of the base, and opioid or overdose reversal as the third corner of that triangle. She described that as, in her slide, as interventions to reduce mortality and link to treatment. And that really is the subject, that third corner of the next few minutes. Is this the right tool to advance the slides? Great. Big green one. All right, excellent. Oh, thank you. So quickly, the mission of Boston Healthcare for the Homeless program, very simply, is to provide or assure access to the highest quality health care for all homeless men, women, and children in the greater Boston area. And big green one, right? Ah, okay. Thank you. So, and as many of you know, because we've presented this slide a million times here, overdose has become, and at this point I would say likely far and away, the leading cause of death among our homeless patients in Boston, as Dr. Baggett, who's in the audience's figure here, showed us back in 2013. So very briefly, if I haven't shared this slide with you, this figure from the table is showing you mortality rate ratios with comparing mortality from various causes between two different time periods in our population. One of those time periods was approximately 15 years ago, and is reflected on the left. And the other time period was now a whole decade ago, 2003 to 2008, reflected on the right. So a mortality rate ratio of 1 means that that cause of death was the same among homeless people in Boston between the two time periods. Moving to the right, it was more common in the more recent time period, and to the left, more common in the previous time period. And this slide, this figure really to me tells the story of an emerging new epidemic that we saw both earlier and in a more magnified way among our patients. And so you can see here that while we mitigated to a large extent deaths related to HIV and AIDS in this time period for lots of very good reasons, not the least of which was the development of antiretroviral therapy, but also I would mention the Ryan White program more broadly, and specifically housing targeted to people with this disorder. That was completely offset, almost exactly offset, by deaths from drug overdose, 81% of those from opiate overdose, which is really disappointing. This figure, this work was very mobilizing for our program. I would like to also just point out that cancer and heart disease were a very close second and third in these time periods. And the sizes of the boxes here show you how many deaths were happening relative to the other causes. So it was in this setting, and this data Travis began to share with us in about 2012, that we, out of desperation, began to try to be more innovative with our addiction programming. We took on lots of different new programming for the periods of 2012, 13, 14, 15, and despite all of the things that we did that I won't list, we were still having and actually still have 2 to 4 overdoses every single week in the building where we work, just across the street. And so it's really out of this desperation that we opened SPOT, which I'll describe in a minute, 2 years ago, almost exactly. It's a non-judgmental space focused on reducing the harms of drug use, where we've provided medical monitoring and harm reduction services and various other supports for about 800 unique drug users in over 7,000 visits. And we are learning so much. It's really transformed our relationships with people who are using substances. And from the beginning, we've tried to design that program by listening as best we can to the needs and the concerns of people who use drugs actively. Our aim has been to save lives and to let people know that no matter what you're doing, we want to care for you. We love you. You have worth. You don't need to stop using before we can start helping you. So in terms of the objectives of the SPOT program, they were very simple. They're listed here. Down to its core, it is a program built on engaging people who mistrust our medical systems profoundly. And that engagement, that listening is at the heart, really, of what I think it means to be innovative in the midst of this epidemic. So let me describe the program to you, and then I want to tell you about our research efforts to evaluate it. This is a picture from inside SPOT. We offer the following services. It's a small room. If you haven't come over to see it across the street, I encourage you to come over. I'd be happy to give you a quick tour. We basically monitor people medically when they have used substances and are worried about or at risk for overdose. People don't often understand why there's a need for that, but I'll show you in a minute. We obviously treat overdose. We use a lot of supplemental oxygen, and we use a little bit of IV fluids, and we use a little bit of naloxone, as I'll show you in a minute. We provide a lot of counseling about safer injection techniques. We connect people to any other healthcare services they may be interested in, and we obviously distribute naloxone rescue kits. Our staffing model is very simple. It's a small room where we can fit approximately 10 patients at a time. We staff that with a registered nurse who specializes in addiction, a harm reduction specialist, completely non-clinical, and I would say really the linchpin of the program, who really helps in building relationships. Occasionally we have peers, that we're lucky to have peers in the room to offer support, and we have a rapid response clinician in the building available for medical emergencies. I just want to point out that we had a lot of consumer involvement in the design of this program leading up to it in lots of ways that you can see here. Probably one of the most interesting things that we did was to involve a person who is actively using heroin and fentanyl in the interviewing of the staff that we hired for this room. And that was a very interesting experience. As an administrator, I knew exactly who we needed to hire from watching those interactions. So I want to very briefly tell you about the research that we've been doing with SPOT, and some of it is very much in progress, but basically our roadmap, if I had to summarize, consists of three studies that really looked more at the environment surrounding this intervention. The first one was a convenient sampling of consumers, 240 of them who use the syringe exchange program right next door, about their willingness to use this kind of programming and for help in getting feedback about various elements of design of the program. And not surprisingly, most of the people that we interviewed reported willingness to use this kind of program, and others like it. And in fact, people at the highest risk of overdose were very likely to want to use this kind of programming. We learned a lot of interesting things, though, in this study, like 70% of active drug users said they would not use this kind of programming if they had to give a name. So we knew that we had to figure out how to manage that, which we did. Second quick study was really a study that came out of a lot of engagement that we had to undertake, which I'm grateful for, with the community here in the South End. There are 9 neighborhood associations in the South End who I think were very opposed to us opening this kind of program when we first started talking about it. So we spent probably about 50 meetings at night with the community associations trying to get buy-in. And in the meantime, we decided to do a survey, again, a survey through mailings to 2,000 addresses in the area, residences, asking about attitudes around addiction. We did that at 2 different points in time, several months before and several months after opening Spot. And we noted, probably having nothing to do with Spot, but probably more having to do with the media, that there was a significant increase in community knowledge about drugs over this time period in 2016, and that there were pretty favorable attitudes about harm reduction programming here, and that those tracked though pretty clearly with a few variables like education level. Finally, probably one of the hardest studies that I've ever participated in was a very onerous public order study that we conducted and modeled after one that was done in Vancouver after the opening of Insight there, the supervised injection facility. So we had a team of people who looked at various metrics of public order related to drug use in and around actually a 500-meter radius of our building on Massachusetts Avenue and Albany Street, including things like discarded syringes, et cetera. And what we found basically was that controlling for a million things, including weather, we found that Spot was associated with, even the small program, was associated with a significant decrease in the number of observed people in public who were over-sedated. But that all of the other metrics related to injection drug use in a public space did not change. So this did not worsen or bring in more drug use based on these metrics. And this was a study that the neighborhoods asked us to do. And I'm not sure I would ever do that study again. You can imagine the alleyways we've traipsed across every Monday, Wednesday, and Friday for 22 weeks. Okay, next category of research or evaluation, I should say, is sort of participant population and kind of this internal dashboard of the patients using the program and some of the details about that. So a quick snapshot to share with you of exactly 2 years of operation. We have had in this room that fits 10 people, about 7,100 encounters among 839 unique visitors. 34% of them are women. You might be surprised to hear that we only administered naloxone 47 times. However, we probably would have administered it quite a few more times if we hadn't administered oxygen 488 times. We are estimating that we've avoided approximately almost 1,000 emergency department visits. And these are where the nurse said, if I didn't have this infrastructure right here today, I would send the person, I would call 911. We have 24% of the people who have used the program have been referred directly to addiction treatment from the room that day. Most of the time, we're actually taking people into whatever kind of treatment they're interested in, mostly office-based addiction treatment with buprenorphine or methadone maintenance or detox. And then furthermore, trying to track, which was very difficult, the people that we referred into treatment, how many of them actually accessed it. It appears to us that 55% of those 24% actually accessed treatment. And then 22% of people we've connected directly to other healthcare services. So this kind of programming, I think it can be very successful in engaging a very high-risk group of people in treatment. So what we're learning here basically, again, is that this cohort is very high use. The nature of our relationships in this setting is so different from any other healthcare setting I've ever worked in. And people are telling us and teaching us a lot more about the cocktail that is commonly used right here on MASS and CAS. And the cocktail most often is these 5 substances used together, sometimes even sold together. We are right now in the beginning of analyzing data to help us describe in a very old-fashioned case series a polysubstance overdose syndrome. We would like to also soon describe just the substance use patterns and acute and chronic healthcare needs of the population of people using the program. In terms of the polyoverdose syndrome, I want to show you some very common vital signs that we monitor in the room and treat. And I guess what I would say is that we are very often seeing bradycardia that is severe and hypotension that is severe, even before we're seeing respiratory depression, which looks different from a pure opiate overdose. We're learning a lot more about the time course of that as well. So the polysubstance overdose syndrome case series, our aim, again, is to use retrospective case series with anonymized data of SPOT users to develop an understanding of key clinical characteristics of this syndrome. Individuals who have ingested the most common cocktail, we hypothesize, experience severe bradycardia and hypotension that differs from a more classic presentation. Our sample right now is relatively small, but we're working to expand that. We have right now 57 SPOT users who have visited SPOT in a recent 6-month period and have either experienced a systolic blood pressure of less than 90 or a pulse of less than 60 or both, and have had at least one sedation level documented that is greater than or equal to an S4 on a simple anesthesia scale. We're hoping to expand this soon, this number. And without going into very much detail, I'll just quickly sort of give you a glance at the ranges of blood pressures we're seeing for that sample of 57. Bradycardia being one of the most profound markers here, and severe bradycardia even quite common. And I'll show you as well that among that group of 57 who meet those criteria, there are most often 53% of over half of them are reporting to us having used all 5 of those substances and then various other combinations. So I guess what I would like to say in conclusion about research in this kind of programming that is most importantly focused on access to this care, even at the expense of knowing a person's name, knowing their toxicology results, if we were to do formal toxicology, et cetera, that there are not insignificant issues around obtaining consent in this setting. Some of the issues include, really our desire to maintain a trusting relationship. But also participants' engagement in illicit behavior makes them less likely to agree to be telling us a lot of detail that would be helpful in a research. And then finally, that sedation, actually, and its impact on the ability to give consent is one of the hardest things about conducting research in this setting. So we need to also prevent research from being viewed as encouraging participants to use again. At SPOT, we are beginning data collection at an unknown point in time in the particular syndrome that we're trying to describe. And then finally, of course, it's difficult to follow participants over time, given the instability in their lives and given very limited resources. The last column of research that we would really like to get going to evaluate this kind of programming is much more around impact. And the problems here are access to data sets that we need, and we need help. We would really like to know the impact of this on overdose rates locally, as well as emergency room utilization. We would also like to know, with much more detail, and being able to follow people through a continuum of care, what the impact of this kind of programming is on treatment initiation, et cetera. So in conclusion, there's a disproportionate effect of overdose deaths among the homeless population here. Harm reduction services, I would argue, play a crucial role in the substance use disorder treatment continuum. Trusting relationships with people who inject drugs really offer the promise of discovering and tailoring interventions like Dr. Valco was mentioning today that have high impact. And yet they also present challenges with conducting formal research. So I wanted to give a quick thanks to lots of people in my institution at Healthcare for the Homeless and the Syringe Exchange Program next door, who have helped so much with this work in general. And I just want to say in closing that I have lots of ideas about how to solve this crisis, which continues to loom larger than ever in Boston. But the only thing I really know is that creating this kind of program has taken us closer to the inner worlds and the pains and concerns, pleas for help, and even the joys and triumphs of our patients than ever before. And I feel like the closer we keep ourselves to these stories, listening for both the voiced and the unvoiced needs in their words, the closer we'll be to finding innovative solutions. Thank you.
Do we have questions?
I wanted to know if maybe as next steps you're trying to provide also a setting that people can also use there.
That's a great question. So we obviously stopped short of allowing people to inject in a place where we can observe them, because that is illegal currently in the U.S. I think that is something we absolutely need, and there are plenty of cases from SPOT that has sort of shown us that very directly. But again, this kind of programming, beyond being able to be there at the time of injection, which I think is needed at this point in the epidemic, we really can't stop deaths that are related to fentanyl at the time of injection. I think what we can impact here is overdose deaths that might occur as a result of polysubstance use, which are more prolonged. It takes a long time for all these substances to reach peak effect. People have time to walk in the meantime and say, I'm worried about how much clonidine and heroin I took today. But I do think that that's something that's desperately needed. We are seeing many overdoses still in our bathrooms at the point of injection because we are not able to observe them. I think we need to do that. Thank you.